Hello, everyone. Let me present the next case. It's about 66 years old male patient with high-grade stable angina. The patient is also with known left main and two-vessel disease. June 2022, it was performed PCIF left main LAD and LAD. The patient is with risk factors, hypertension and dyslipidemia. From ECG, we have sinus rhythm with no STT changes. The echo demonstrates preserved left ventricular function, normal kinetics, and valve function. Here you can appreciate the coronary anatomy. It is, you can see the ostial instant restenosis of the left main. From the spider, proximal instant restenosis, osteostenosis of circ, and the first diagonal branch. The right has no changes. That's the case.
Okay. Hello, Robert. Did we have a connection with the cath lab? Hello, Eva. You hear us? Имаме ли връзка с катетеризационната? Доктор Золумова, мога ли да те помоля да... Okay. Hi, Robert.
Oh, I'm sorry. It disappear.
I hear
What?
Akiko.
Can you flash? Maybe I was broken. I don't know. Oh, good. It's good now. Now picture is coming back.
So as I see, they will do an IVUS.
This is high definition.
Yeah?
Yes.
You know.
This
Still
is
in
very
the catheter,
gentle device.
I guess.
You are in the cassette. Yeah, right.
Fragile.
Okay, so I will go.
Yeah, the second dot, that's IVUS.
Yes. So let's start from the mid LED.
Okay. Do you want to start? Flash. Okay, flash.
No.
Okay, good. Okay, do you want to start?
Yeah, I'm ready.
Can the operator switch to see the IVUS from here?
So that's a circ. And this left is super clean. Nothing. Oh,
think that they
interesting.
need
Super
to-
focal neointimal aplasia. Stent, no deformation.
Yeah.
And actually, it's not ostium. It's actually
Okay.
a little bit inside.
Okay. So
You see?
could we do?
Okay, so this is a proximal LAD, this is circ. Coming back, this is distal left main, super clean. Nothing. Only here, super
But
focal.
we see the neointima right here.
Sure.
It's
So Lume is only.
yes.
So
Yeah.
it's all neointima. Stent expansion is super good. And they actually, it's not actual ostium.
But what about the? Could you go further?
This is
So
ostium.
it's out. Okay. Yeah.
So
It's already. It's
Yeah,
already even here.
actually, this is a
Yeah.
little bit.
This is something more organized.
No, this is no. This is only blood.
No.
No.
Look at that. This. That was visible on the angio.
Oh, you mean the deformation?
No deformation.
This is 2-layer.
No.
Maybe it looks as
From 9 to 6. From 9 to 7. This is. Yeah. Exactly.
Yeah, this is kind of small No, this is some deformation. You see the double layer, right? There is no tissue.
So this is deformation. This is envagination. Envagination of
Yes.
Yeah.
of the stent.
Robert, did you hear us?
Are you hearing us? Are you?
Okay. We
I-
hear you. We hear you very well.
Okay.
Just,
So we are very sorry. Just to say, we are very sorry. We didn't know about this. The transmission is already live.
yes.
do you know already the case from
Yes.
clinical point of view?
Yes.
Yeah.
Yes.
So might be we will go from the diagnostic part of the procedure. Can we show the sequential injections? And as you see, the right coronary is fine. And now stop for a while. Now you can appreciate the just in the moving. Now you can appreciate in the let's say proximal 1/3 of the stent, a kind of plaque, kind of stenosis, not very tight, but still there is something. However, we see from angiogram, we see that the stent is well opposed, well expanded. Sorry, and it's good. So next.
Did you give some nitroglycerin?
And then you see that this 1/3 of the stent is limited. The lumen of this approximately 1/3 of the stent is limited by the plaque. This is 7 French Judkins 3.5 guide catheter. You can also appreciate the tight stenosis, very short one in the orifice of circumflex artery. And then you saw that we succeeded with 6 French 4.0 Judkins catheter. And we started from the mid-LAD pullback with high definition assist IVUS. And then I will ask Akiko to present you and to translate these images into the description.
Sure. Can you see the IVUS? So this is about 8 months old stent. So this is a proximal LAD, and stent expansion is quite nice, and there is not much neointima hyperplasia. So let's start. So this is a proximal LAD, and now you see the circumflex on the top, which was wired, and this is ostial LAD, and still inside is super clean. Go to the distal left main, and this is how it looks like distal left main. Good expansion, not much neointima. Come back more in the mid left main, still nice, 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 good stent expansion. And suddenly you see, okay, yeah, 2 things. One is if I come here, you see a lot of neointima tissue inside. And if I measure the smallest area, the lumen is 3.2, and stent area is 9.5. So good expansion, a lot of neointima. That's number one. Number 2 is if I go to a little bit distal, and this is actually somehow interesting picture. In the 9 o'clock, even this is only one layer, you see the multiple layer. Maybe it's a little bit difficult. So here, I see the double layer of the stent. Okay, I will show. Maybe this is, wait a second. So I'm sorry, this is even more clear. So 9 o'clock, this is only one layer of the stent. But you see the double layer of the stent on the 9 o'clock. This is kind of like the very focal deformation. I'm not sure how this deformation effect of this neointima hyperplasia, but this is just one of the observation.
Do you think
and
that
in
this
terms
is
of the stent was protruding to the outer, not too much, but that original stent was well opposed and nicely implanted.
Akiko, could you let's say show us the diameter of this most proximal part of the stent?
So this is how it looks like the stent diameter. A little bit eclipsed, so largest one is 4.0 and shortest one is about 3.
So we have the operator of this case. Valerie, what kind of stent you used for redilatation? Do you remember? That was 4.0 or bigger?
2.5. No,
for left main.
Is it this neoatherosclerosis or?
Okay, so it would be good to know it. And then let's follow these, let's say, diameters into the, let's say, distal part of the left main.
So go distally.
Could you calculate here, for example?
So distal left main stent diameter is 3.6, and this one is,
So media to media is at least
Oh,
4.
no, no. Yeah, sure. Let's go to the media to media exactly. So this is how it looks like, 4.5.
Yeah.
And I couldn't measure, but just my best assumption. I think for sure 4 balloon
Yeah,
at least. Right?
so our choice for the treatment of this case would be NC 4
Yeah.
4.0.
millimeters balloon. Let's calculate the length of the stent, of the left main. Yeah. We can discuss the other one.
It's coming back to my question. What do you think about the neo-atherosclerosis in this stent?
So distal left main up to the stent length is 11 millimeter.
So we could take 12 would be nice to redilate everything.
Not,
And
yeah,
can we calculate also the diameters for the proximal LAD?
Защото аз говоря някакви неща.
So we don't want to affect.
Очевидно не ни чува.
Calculate the diameter?
Yeah.
Media
Media to media.
Media to media, this is osteo left LAD is 4.2.
Okay, so 4 is safe. Unfortunately, we cannot assess the circumflex artery. Could we show how does it look
Why
like?
don't you try to make a run in the circumflex?
So that was
this IVUS is with this IVUS it is possible. It is very low profile.
That was my question to the moderators, to the panelists. What about the circumflex artery? Because we see relatively short
it is critical,
but tight,
by the way.
Tight lesion.
Is critical.
The circumflex artery is not a big one, but we have already wired this artery, and we can perform the second run from circumflex artery. Okay, so let's pull back.
Gianluca, what do you think about the neo-atherosclerosis in this case?
This is not a neo-atherosclerosis. This is just neo-intimal hyperplasia.
Okay,
you got your answer.
The expert said.
I think it's just about the time.
Akiko, I have a question to you. How you differentiate the neo-atherosclerosis from neo-intima?
Sure. Neo-atherosclerosis should have the atherosclerosis. By IVUS, atherosclerosis should be either attenuated plaque that represents lipidic plaque or calcium. This case, I see only like soft tissue, which is typical neo-intimal hyperplasia, and then this is not atherosclerosis.
How could you show?
I mean this very proximal where there is like a 2 layers of stents, but not obviously there is only 1 layer of stent. So this is for that segment of the stent is my question. Just at the very proximal part where it looks like 2 layers of stents.
Because Dobrin, I'm pretty sure that this is a kind of invagination of the part of the stent. So therefore, in a certain moment, you see, let's say, 2 layers with a lack of layers between them. So this is my explanation.
Because for me, it is still.
Yeah, we can get easily fooled, right? We can think it's neo-atherosclerosis with
but
a
in
little
terms
bit of calcium, maybe.
Minimal stent area,
so it's a difficult
how big
image
is it,
to interpret. If
Akiko?
you're not,
In the left main.
Left main.
Yeah, I think smallest maybe somewhere here. I think close to 9.
Very easily you passed.
Yes, that was without any let's say, resistance.
Yes, with this IVUS, this is not a problem, as I said.
Yeah.
It's a much lower profile.
Okay, can we start?
It's
This
like
is
the
chunk
both.
of the disease.
Like the both.
Can we start, or do you want to?
Let's flash.
No, this is just disease.
It's already disease.
Okay, can we start? Or
Yes.
do you want to go a little bit more distal?
Okay, I will go more
What is the
distal.
speed
Okay.
of the pullback? Because
Okay,
here-
perfect.
Okay.
Okay, let's start from, now we are talking from the circumflex, and this is a big OM branch, and now you see the disease, and everything is like soft plaque. This is more disease than what we thought, but circumflex is coming. Okay, actually, it's actually clean. Not too bad.
But first of all, the circumflex artery is not a small artery, but very diseased, diffuse.
Yes.
Yeah, actually, this side is more disease.
Yeah.
Okay, let's talk. Let's review. So starting the supernormal but small artery, and coming back, this is a big branch, and after this, it's actually almost plaque. This
Yeah.
is soft plaque. But anyway, this is also soft plaque. And what is our interest is ostium. So come back, still disease. Okay, still disease, oh my goodness. Okay, here is actually you have enough, not enough, but some lumen, right? This is a proximal circ. Okay, so this is really exactly ostium. This is a LAD, and this is the osteocirc. So if I measure the lumen area of the osteocirc is something like this, 3.0, which is not super big, but which is not super tight as well. But even more distally, this is a tight. That's how it looks like.
So even if we correct, improve the proximal part, we have still a lot of disease inside. So let's treat only left main without circumflex artery. So this is my
I
my
agree.
proposal.
Yeah.
But if there is some plaque shift after ballooning,
But
This-
we are talking
this
now.
is-
We are talking about circumflex artery. So then my suggestion is just to focus
Concept.
on left main. If we don't destroy the circumflex, then we can
Yeah,
follow
I
with
think
the.
if you treat the circ, you should do the physiology. I'm not sure that's significant or
No,
not.
I'm pretty sure because we should be a little bit conservative because we have, in a way, a stent failure anymore. Let's
Yeah.
treat this one and see whether it's going to be
Yeah,
all right
yeah.
in the future.
Yeah.
Because if we treat the circum, we need another stent put it there. I'm not.
More complex.
It is
And-
more complex, and we see that this guy is not bearing well the stents because, from what I see from the IVUS, there is no big issues on mechanical problem with the stents for this restenosis finally.
Correct.
Yeah. So
Okay.
in terms of this diagonal branch, so let's move.
Definitely.
Let's say the decision after the treatment. So our proposal is after all of these measurements, the left main is more than at least 4.5
Yes.
in size. So we decided to use a
Cutting
balloon with 4.0, and the proposal of Valerie was scoring balloon. So it's still relatively fresh
scoring
stent.
scoring or cutting? Which one?
3.5 or 4? This is at least
Wedge. This is wedge scoring balloon.
Yeah.
Yeah, sorry.
left main is media to media is 4.5 and stent is close to 4. I think this is
No,
under.
this is just for the beginning, and
Ah,
after
okay,
that,
okay.
because it's a scoring bone,
Okay.
after that we are going
So
to take
I will pull back.
a non-compliant bone,
Okay.
4, and if necessary. Do you agree?
Robert,
Yeah.
is Gianluca. Do you expect
Just
to
to-
treat also the distortion of the proximal part of the stent, or just to treat
Is
the
it really distortion?
neo-intima proliferation?
Not only intima proliferation, we would love
it
to
is
correct
very
the
short to
let's
be
say
distorted,
the
this
previous
stent. Could
shape
this
of
be
the
a
stent.
phenomenon,
The question is whether it will be possible because the shorter
maybe
is
we can
this
see from the circle,
let's say deformation probably will be more difficult to get it. But let's see.
All right.
And the next question is, what after the scoring balloon? Because this is left main, and what you will do? The drug-coated balloon, new stent.
I will
Nothing.
tell you honestly that first of all this is Science Pro, yeah. Science Pro,
Yeah.
as far as I remember, is free of drug after even 3 months.
Yes.
Might be a little bit longer.
No, but this is, this is this is typical for all drug eluting stents. After 3 months, they are free of drug elution, let's say.
Yeah.
And the point is to elute for, let's say, up to 120 days. So probably there is no drug there, but
Yeah.
Yes, there is definitely no drag there. I mean that because to have a good drag elution, you need some time, and to inflate the drag eluting balloon into the stent.
It's not easy to let's say, to position this this scoring balloon. Let's try
In my
right
view,
now.
if we go for ballooning and we see that the result is good, and
we need to
we
dilate.
put
It's,
a drag eluting balloon with another drug, I mean paclitaxel, which is different from the Limus,
3-0.
and we provide a good image and
no
after
the regular.
this
Regular.
procedure by IVUS, we will be safe to leave this in this without stenting.
Just my indecent question. If it is true that some causes for this neointimal hyperplasia would be, it might be a stent deformation distortion.
I don't think so.
Okay.
Yeah,
but
because-
I mean, I'm just indecent, I told you. So just think that this is the cause. Is it a stent deformation possibly to be treated just with balloon?
Yeah.
Or it's better to treat it with the stent? Because for what I know, usually stent deformation is hard to correct with balloon.
I think like by IVUS standpoint, this deformation is very short,
Okay.
and in terms of the angle is also like the 60-degree. It's even I wouldn't mention it's very short and small, and what wrong for the stent deformation is very deformed, and then actually after deformation, the minimum stent area is smaller than original because multiple layer. In such, you have to open up better. Or because of the shortening of the stent, you miss the original region. In such, you have to put additional stent. Those two things is important. But this deformation is only almost like incidental findings.
Okay, so it's no clinically relevant or
I agree.
pathophysiologically relevant. All right.
Akiku will tell, but the deformation, I mean, the restenosis is distally to the
stop here.
deformation.
I don't
And
want
in
to
fact,
go inside.
the length of the
This is only-
deformation is much smaller than the distance
okay,
from the
let's
deformation to the restenosis. So, in my view, it is difficult to associate these
pretty
things
sure that-
together.
Okay, but I told
in a
you,
good-
I was indecent.
Yeah.
What is this balloon?
Let's do like here. I'm sure it's.
The balloon is a scoring balloon, 3.5.
Because I saw that there was this is a scoring balloon, yes?
No, it's a regular balloon, excuse me, we prepared, but the scoring balloon could not
Cross.
cross. So it's a 4-0.
No, 3-0 semi-compliant.
Okay.
Look, it's fully opened in balloon because the plaque is.
But if
Very
we
soft.
open it in
You know,
Just a moment, once more
I'm
here.
if
still
we open it in
afraid
AP, where the
of
plaque was
closure of
most
the
well
ostium of
seen
the
in-
circumflex.
Once more.
Because, and this is a clear,
Just to cover everything.
clear case of plaque shifting,
Robert?
Just a moment.
which in
Okay. Yeah.
instant
And then I will,
restenosis
let's say,
is
go inside and then
it's
we
an
make
issue.
the stand boost, okay?
because,
think-
yeah,
I think the neointimal distribution is only the very proximal portion of the left domain. So I
Yes,
don't
I
think
would-
the
I believe
plaque
this is
shift
a good-
from the left domain to the
position.
circumflex, in theory, is less likely.
Okay.
I'd like to ask a question, a didactic question actually. Is neointimal proliferation acting the same as new atherosclerosis regarding the
Make a
plaque
picture
shift?
with
Or is
inflated
it more
balloon
stable
in
maybe?
AP, Caldo, where we can.
I don't think that there is
But
a,
not with
it
3-0.
is a question.
We need bigger
if
balloon,
there is more
not with
calcium,
3-0.
You can see
in
how the
theory,
balloon is
it should be
expanding
less
from the projection
movable,
in
but
which,
But okay.
in practice,
Ah.
in my
Okay, so let's-
practice, if I regret
it's,
every time when I
It's already
miss
open.
to place
Sorry.
a wire in the big side branch, which is in the area of instant restenosis. So this is a general rule. If you have a
And then we perform
big
a
side branch into the area
Small puff.
of
small
instant
puff.
restenosis, place a wire,
And let's
because
make a,
afterwards,
let's say
after
engine.
ballooning,
Okay.
it could appear that the side branch could disappear, and afterwards
I'm fine,
wiring
I'm satisfied.
became
Then
Very
we can
difficult.
do that
Very
with this
difficult.
4-0, okay? Let's exchange.
I think that the new window proliferation is more
with
mobile
3-0 you will
than
see
plug.
nothing. For
Do
sure.
you remember the case in National Heart Institute where we ballooning recoartation to a
yes,
stent?
yes.
And we put a filter,
Yeah.
neuroprotection
yes,
filter,
yes,
and we
yeah.
capture a
I
lot
don't
of
think so.
new
Yes,
productivity issues.
that was a case from 10 years ago.
Yeah.
And we published this in JAC, by the way.
Yeah.
That you're right that I'm really old. I start to forget.
Okay.
But that was really amazing case. And yes, we catch material and we
I
just
think that is more mobile. I don't know if there is any study. I don't think that is any study proving that is more or less mobile than an atheroma. But
yeah. Okay, so can you explain us what you're doing now, Robert?
Yeah, after this pre-dilatation with regular semi-compliant 3-0 balloon, now we try to position this scoring balloon 4-0, 12 millimeters long, and we will try to do simultaneously inflation and recording, showing whether we see the fully open balloon and stand. So this is the idea of Valerie. I like it.
Actually, you are with the 6 French guiding.
Yeah.
So you had to be careful with the space in the balloon, because this scoring balloon and 2 wires, it could be a little bit difficult to manage everything.
Yeah, Witcher, you know.
Maybe you have
Yeah.
twisted wires in the left main
Okay.
with the wire from the circumflex. This is the reason.
So first of all, let's say we are safe with this second work. So I will pull it back. This is this one. Yeah.
Okay.
Okay.
This is a run through.
Yes, this is answer.
Sometimes there is a crisscrossing of wires, and the easiest method to deal with the situation is just to change.
I am
the-
not a big fan of this particular, let's say, balloon, but
Now you have it.
this is 3.5, not 4.0. 3.5. Okay.
This is what we decide to
Okay.
to go gradually.
Just small puff.
It's a good position for the. Maybe not go
Just a little,
too
just-
deep,
just small
because
puff.
you're very close to the
yeah,
circumflex, and
we'll
it's
be
better
happy
to
to
escape.
withdraw a
There's
little
a
bit.
jump.
I think that this position is
That's
very
a
good.
Okay, okay, go. No, it's
Okay, this is a very interesting way to control the inflation of the balloon.
yeah, full. At least from
This is something
projection,
new.
it was full open.
Yeah?
What was the pressure?
Yeah.
The pressure of the balloon. What was the pressure of the balloon?
16 atmospheres. Okay, so once more. Let's So small. No.
Maybe you can keep it for 10 seconds. Don't expect
Okay.
that the balloon will
50
achieve
seconds,
the
okay.
target diameter just in 2, 3, 5 seconds. So just need a little bit
Okay.
more time
Back.
to fully open and to reach the desired diameter. So a little patient, it's always good in
Small puff.
those situations.
I will remind you this.
Okay. So let's make this.
This is
let's
a
say
note to me
the one,
or
okay. Let's make Angie. Okay.
Valery?
Yes, that's me.
I hear you.
So now we need IVUS.
I expect
why
that the
not,
result with
just a
IVUS
proposal,
should be good, but the main problem is what to do next, still. And
Maybe we should
actually,
go
for
with
myself,
the
I don't have an
IVUS,
answer.
distally to the first diagonal because there
I
is some,
personally, this type of patient would
proliferation
send
there,
to
at
surgery,
least from angio.
to be honest.
Would you like to do a show of hands with the public, maybe?
Okay, if you want, we can vote. Who think that the patient should be treated by PCI? 3, 4, 5, 6,
Okay.
7. Dr. Marzianov, you're for PCI?
You
or
are
for
asking
surgery?
about the duration of DAPT?
No, about the revascularization.
Okay,
mode.
so
Yes, I saw that.
maybe
It's okay.
we will be 50-50.
Oh, now it's need
Flash.
flash.
Here are the most endurant people now. Those
Can
who
you flash?
survived till the end.
The Highlander.
Highlanders, yes. The Highlanders.
So you wanted me to put very distally in LED?
No, to put it just distally to the diagonal because there is some
Okay.
proliferation.
Okay, no problem.
Just at the point of.
So we'll perform additional pullback for the mid LED to assess proliferation visible by angio. Once more.
That's enough.
Let's
That's pretty.
that's pretty good.
Okay, let's start.
Okay, we are ready.
That's a diag. Looks okay to me. That's a suck. I think almost like disappear.
Okay, so might be there was some thrombus.
No, I don't think so. Yeah. there
Might
is-
be that was also a kind of thrombus.
Oh,
because-
you mean the original region?
Yeah.
Okay.
Because if there is nothing, so it means that was also a thrombus.
Okay, so let's go back. And this is a distal to the diag, which we worry, and this is a diag. So I think like, okay, lumen. What do you think? I don't
Yes.
see any issue.
We have done a kissing balloon inflation 2.5 here too. But
Oh,
still,
really?
Yes, but still the diagonal at angio seems some stenosis, which was not as we.
Can we
as
check
have it
the woman
immediately
area at
after
this
the
point?
procedure.
Just let us
Yeah.
let us calculate everything, and we will
Are you talking the distal to the diag or left
because
domain?
now we are talking about the mid LED.
Approximately
see.
to the diagonal, it seems that there is some proliferation, but it is not big. I think it is seen if we can. If we are
Yeah,
able to
that's
see-
enough. Right? Okay, so go back. That's a circumflex, and this is a left domain. And then I'm almost not sure where the original region was.
Yeah, that was thrombus.
Okay, so I think somewhere here.
Here we have sign
Okay.
of what we.
Okay, so I think the lumen is like this. I think it's good.
Furrow balloon, drug coated balloon, and we are done. That's my proposal.
Immediately
First of all, so can we calculate the minimal stent area before the procedure and after the left main dilatation?
stent area?
Yeah.
Okay, so for now, how big now? Okay, this is generous. So outside of the smallest area, the stent area is 9.7. And then go back to this one.
Very close to 9.8, as you suggested
Yeah,
in
yeah, I
Excel,
think
yeah?
so. Actually, quite similar. Okay, this is 9.5.
Yes.
So stent didn't change, and lumen get bigger from 3.2 to.
So it means
Yeah.
you used 3.0 or redilated?
Something wrong.
4.0. Ah,
That's why we
recoil.
cannot achieve it is the same
Yes.
because we are with 3.5 balloon.
Yeah,
The pot was done with 5, with 4 balloon. So probably we should go to 4 and put a drug coated.
The question is regular or, let's say, drug-eluting? It's
I would
It's-
prefer
drug-eluting?
no, first non-compliant and after that drug.
Okay, so we need 4.0, 12 millimeters long. Yeah.
Da.
Okay, so let's...
Robert.
Yes.
But I mean, if or
Yeah,
you are a musician, and you make all the tissue before disappear,
Yeah.
or is there something wrong with the initial?
what about the
definition of the tissue?
What about the antiplatelets drugs in this particular patient? That was prasugrel, ticagrel, or clopidogrel? Are we able to check it?
Well, the guys from
Valerie, what kind of antiplatelets therapy that the patient, let's say, was given? Ticagrelor. So the question is whether he was systematically
anti-aggregated or anti-thrombosed,
yeah, no, but
anti-coagulated.
the question is whether he took or not so he's yeah, really? Ah, okay. So it means that that the antiplatelet drug was a good one. That was ticagrelor.
Don't you think that it will be good to shot after you inflate this device afterwards to shot a picture of a wall left cystine in epicranial just to see if something embolized to the periphery?
Okay, we'll do that.
After
Yeah.
this balloon inflation.
Yeah, after this.
Small puff. I guess it's fine.
Looks good.
Yeah. This is 4012. 16 atmospheres.
16. 1-6. Yes?
I said 60?
Yes.
That was my mistake. I'm sorry. I had only 45. Okay. Too
And Eva gave 16. Just for the audience, when you use a drug-eluting balloon, this is only for just a driver of the drug. You should not rely on the pressure of the.
But this is regular. This is regular balloon.
This one.
But NC.
This is not a
not a
drug-eluting.
16 again. 16, yeah?
This is not a drug-eluting balloon.
No. That was the.
Okay. I decided that you took drug-coated balloon. Okay.
So in the meantime, we observed a kind of less expanded, let's say, balloon in a proximal part. So I was suggested by Yves to increase to 18. So we did it. And then let's perform small injection. Okay. Yep.
You see the diagonal.
I cannot see well the distal LAD.
We'll see in cranial position in a moment. I will pull back the balloon, but we are looking at the diagonal branch. It doesn't look great, I would say.
But this is the same as with the circ.
But since this is stable, without impairment.
Probably the distal LAD is not seen because we have the
Okay, so let's make a
the
cranial.
wire with a loop and it is compressed.
But you know, the patient is stable, the good arterial pressure, heart rate without problem. Small puff, just small puff. Okay, let's. You some nitro? So it's up to you, but I don't want to assess stent right now. We are looking for potential distal embolization because Gianluca is afraid of that.
No, just because I didn't see the tissue before
Okay, so let's-
into the IVUS.
Can we do? Yeah.
We
I'm
are
ready.
a little bit here discussing how
No.
what
There
could
is a loop distal of the wire.
result-
Probably it is stretching the
Yeah,
vessel.
but distally is filled without problem, and now we
Alright.
can use these additional projections to,
No, the
to
flow
show
is
the
brisk.
proximal part of the stent.
Yeah.
But anyway, the tissue disappeared. I don't know how.
Now I will try to.
Okay. So, would you
Small
plan
injection.
now to
Okay, now
use
this-
drug-coated balloon?
Okay.
Robert, Eve, Eva?
Yes, we have the coated bone, the depth with me, just waiting to.
So first of all, we don't see this material, which we classified at the beginning at the plaque.
Картина пред то беше в кълдауна.
Okay, and what type of drug-coated balloon will you
That
use?
was this.
This is Caudal, this is what I want.
Yeah. Okay. Let's try.
This is Pantera Lux.
What size?
The size is going to be 3.5.
Okay.
And we are going to expand it to 12 atmospheres, which is 4.1.
Let's wait. Whether it's not centralized.
Do you think that maybe 4 balloon will be better?
Okay.
Yes,
so
but we
let's-
don't have in the moment.
are you ready?
You know, we have some issues in Bulgaria with these balloons because
It disappeared.
with
Yes, I know.
this
Disappeared.
health
We reached the
insurance.
limit.
No, no,
They-
with the
they-
limits of the numbers. The numbers are more than
Yeah,
was
no.
expected. You should know this very well.
Yes, by the way, now the proximal LAD looks stenosed.
Yes, that's why we did the IVUS in this more distally, starting from more
But
distally.
this is a little
And,
bit above
the
4 square
minimal-
millimeters.
The minimum woman area was
4.3 or something like this.
4.3.
So by IVUS, it's okay. 4.7.
4.7.
Okay.
With some intimal proliferation, but still the woman I think is acceptable. And
But you know,
probably,
if we decide to treat this LED, we have to treat diagonal as well.
Yes,
I think we
absolutely.
we should be more conservative, as we decided just to see what is the result of the left main after, let's say, 3 to 4 months, and if it is let's say sustained, we are going to evaluate the circle
Okay.
and the diagonal and treat them.
So the final decision is just to treat, the last touch will be with paclitaxel eluting balloon.
Yeah.
4-0,
3.5, but if we went to 12 atmospheres, it is 4.1.
okay. So
I just explained we
need
have
spider,
some
yeah?
issues
We
with
need spider.
the health insurance.
Okay.
That
I
will
will
be a
wait.
big
I will do that.
sacrifice
I will
from
do that. I will do
Biotronic side. But they will survive this balloon, I'm sure.
We cannot catch you up, Dobry.
I will explain later.
Okay.
Center. Let me see. Okay. Okay, I'm going. Okay.
So now there will be a drug-coated balloon inflation. In general, as I said, don't use the drug-coated balloon for lumen
Just small
dilatation.
puff?
It is only for drug delivery. It is not for to you should
Small
before
I
applying
guess this is fine. Okay.
any
Let's go.
drug-coated balloon, you should prepare your artery very well. The diameter of the drug-coated balloon should be equal to the balloon with which you prepare the artery. If you will use
This is-
3O
this is
balloon, drug-coated balloon, you should
14?
use
14
3O
atmospheres.
balloon for the predilatation. If you
This
use
is better
2.5,
also
So
if
my
the
usual
result of the,
approach is just
MC
to
balloon
repeat it
Yes.
once
is
more.
equal
two shots.
or less than
And 20 or
10%
30
Yeah.
seconds. This is left main.
like for
We have already 30
biosolvable.
seconds, and I
Okay.
think it's enough.
Okay.
a lot of people,
This
I
is what
saw
is
this
recommended by the,
10th or 100th of times that
in some
they
cases.
predilate
which we
with
have,
smaller balloon and then they take a larger drug-coated
this,
balloon
difficult to treat just
to
let me
we
to
put
use it
You want
for
once more?
lesion dilatation and
So
for
therefore,
drug
Yeah,
coating
so
delivery.
therefore I-
This is a
I
mistake.
was a little
Clearly.
bit
And in some instances, we put
And probably
a
this is
second balloon if
the reason
necessary.
for
I
the
mean,
result
increase
after
the dose of
drug-coated
the
balloon
drug.
because
But here we can.
some at least some percent of the re-restenosis is because of improper use of drug-coated balloons.
small puff. Yeah. Okay. Let's do the last shot.
Oh, super. Bravo.
Yeah.
I was.
Ivus. And
The
finish.
question is what for? We let's say that's I am right now I am against because we can hard the stand. It's already the previous dilatation was
We have dilated with a higher diameter balloon. But it's up to you.
I think I would see the scattering of the.
yeah. The problem is that we didn't perform IVUS after 4-0.
Robert, you
Did we
do
perform?
Ivus faster than you explain why not to do.
Okay, let's skip it. If you decide.
No. Because we didn't have 4-0.
4-0. That's why I.
Yeah, because that's what I realized. Only for that.
Of course, this is. Butnete го напред.
I have to bring it closer.
Чак. Меню. Натисни го. Долу не си го вкарала тук. Ивей, тук не е вкарал. Вкарай го в... вкарай го. Ще го щупиме, като се тегли.
Да.
Така. Пусни го сега. Айде, готови са. Давай напред. Нищо, сега няма стрес.
Yeah. Could you? Yeah.
Oh, you need a flash.
Okay.
Промивка.
Flash the port of
Yeah.
the
Okay.
adapter.
Okay.
Can we start?
Yes.
Oh, you need a flash. Can you flash?
Иве, промивка трябва.
Eva, can you flash the, yeah.
Okay, looks like we finished. Okay, too late. Okay, so we have to go back.
Once more.
No. Okay, so we already pull back. So this has to come back.
Yeah. This is. Yes.
Okay, then flash.
Okay.
It looks nice.
It's out of.
Can you go to the silk view? Akiko, can I
No, this.
can I ask
I
you to
think
go
we need enough
into the
flash.
silk view?
There is no setting. I'm not talking the device. Yeah, we need a
Sorry.
setting. Okay, make the good flash. Okay, I think this is broken.
Yeah.
Okay, we done. Oh, looks like it's coming back.
Okay. Fine.
It's okay, it's okay.
Robert, we
No?
are done.
Okay.
We are done.
Yeah,
No, but we took everything, so.
that's good. Okay.
Anyway, small puff, just to see that everything is fine. Okay. Good. We don't need additional. Okay.
Okay, good. Thank you so much. Good job. They leave. No?
But you know, for me, the lesson which I took from this case is that it had to be very soft, very delicate tissue
Yes.
that disappeared completely after two
Balloon.
dilatations.
Yeah. I see this type of the tissue by
can-
OCT or IVUS, and it's almost same phenomena. It's
take
almost
out.
disappear.
Yeah.
No, but
So-
isn't it something left?
Yeah,
next
of
to
course
the-
some, but it's much
Something
more.
was pressed.
Yes, it's some, but it's much almost disappear,
Yeah,
right?
yeah,
We
yeah,
see
yeah,
this
yeah.
type of the tissue. It's typically relatively young, and then the tissue factor, plaque itself is more likely proteoglycan rich and more likely soft. So if we push, actually those proteoglycan disappear, and we see this type of the picture after the just
But-
balloon.
But disappear or or the tissue pack?
I think both. Yeah.
Dissoluted. Dissolution.
Maybe this is a soft tissue which was compressed.
Yeah, compressed and also,
compressed
yeah.
and-
Anyway,
yes, and-
this is all imagination.
Anyway, we succeeded. Thank you very much for support.
Okay,
this
thank
in-
you again.
Good.
Congratulations for the case. It was really interesting. And
Thank you very much.
congratulations
Thank you
for
very
all
much.
the survivors
Thank you, thank
here
you.
in the conference room. Thank you, everybody. And
thank
we will wait you tomorrow morning at 9 o'clock on the Nightmares in the Cat Lab.